Welcome back to The Explainer. If you're an MBBS or a surgical student, listen up, because today we are tackling a super common, highly testable topic, sebaceous cysts. We're going to completely break down the pathology, the clinical presentation, and the surgical management of these cysts. This is a high-yield overview built specifically to give you that clinical edge, whether you're rounding on the wards or sitting for your board exams. So let's just dive right in.
Here's our game plan for today's clinical encounter. We'll breeze through pathology and terminology, hit the common sites and clinical features, nail down those key diagnostic signs, look at major clinical complications, and wrap it all up with surgical treatment strategies.
All right, part 1, pathology and terminology. And we actually need to clear up a massive clinical misconception right out of the gate. So practically everyone on the hospital floor calls this a sebaceous cyst. It makes total sense, right? A sebaceous gland duct gets blocked and it swells up with its own secretions. But your board examiners, they're going to want you to know that sebaceous cyst is technically a misnomer. Pathologically speaking, it's a retention cyst, but because it is lined by superficial squamous epithelium, the most accurate gold star term is actually an epidermoid cyst. Remembering that distinct difference between everyday hospital slang and the exact histological reality is a guaranteed way to pick up easy marks.
Now, what's actually inside that squamous lining? Well, if you've ever assisted in an excision, you already know. It's unforgettable, mostly because of the smell. It's packed with this yellowish, pultaceous material. Basically, it's a thick, foul-smelling soup of trapped sebum, fat, and disquamated epithelial cells that are constantly shedding from that lining we just talked about. Moving right along to Section 2, Sites and Clinical Features. Where exactly are we going to find these things on our patients?
Well, they can pop up almost anywhere on the body, but they absolutely love real estate where sebaceous glands are plentiful. We're talking the scalp, the face, and the scrotum. Oh, and a quick heads up on scrotal cysts. They usually show up in multiples and feel surprisingly solid once they're well formed. But here is your absolute golden rule for differential diagnosis. You will literally never see a true sebaceous cyst on the palm of a hand or the sole of a foot. Why? Because there are 0 sebaceous glands there. No glands, no cyst.
Now, when examining cysts on the scalp, there's a really interesting clinical quirk. Usually, we expect to see a specific diagnostic marker called a punctum, but on the scalp, they often completely lack that visible punctum. So don't let a missing punctum trick you into ruling out a sebaceous cyst if it's on the head. Okay, Section 3, Key Diagnostic Signs. Let's talk about the hallmark physical signs you need to be actively hunting for during your physical exam.
Classic presentation time. You're looking for a smooth, spherical cystic swelling. It could be tiny, just a few millimeters across, or it could be a whopping 5 centimeters in diameter. You're also going to look for that punctum we just mentioned, which is basically a bluish or blackish spot showing exactly where the duct opening got blocked. And here's the kicker. When you palpate it, the cyst is always firmly fixed to the overlying skin.
And that skin fixity is a total game changer for your differential. Imagine you're trying to figure out, is this mass a sebaceous cyst, a dermoid cyst, or just a lipoma? Just try to pinch the skin over it. With a lipoma or a dermoid cyst, the skin is usually freely mobile. You can pinch and lift it right off the lump. But with a sebaceous cyst, because it grows directly out of the skin's own glandular structure, you cannot lift that skin away. The cyst moves beautifully with the skin, but stays totally unattached to the deeper structures underneath. To wrap up your physical exam, let's run through a few quick bedside tests. Because the cyst is stuffed with that semi-solid sebum, pressing on it firmly might actually leave a little indentation, almost like putty. If it's a big cyst, it'll give you a positive fluctuation test, though good luck feeling that on a tiny one. Transillumination, almost always negative, light just bounces right off that dense, pultaceous core. And generally, these cysts don't hurt at all, unless, of course, they get infected. Then it's a whole different story.
Which brings us perfectly to Section 4, Major Clinical Complications. What happens when things actually go sideways? It's super easy for a patient to just ignore a simple, painless bump, right? But what happens when they leave it untreated for months or even years? Well, the complications that bubble up can completely change both how the patient presents to you and how you're going to have to manage it surgically.
You're definitely going to want to commit these complications to memory. By far the most common is infection. The skin gets red, hot, and incredibly tender. If that infected cyst bursts, it leads to ulceration. And listen closely to this one. An ulcerated cyst on the scalp can sprout all this excessive granulation tissue that heavily mimics a malignant fungating epithelioma. The old-school textbook name for that is Cox's peculiar tumor. Pretty wild, right? Then there's the sebaceous horn, where sebum slowly oozes from a wide punctum and literally hardens into a horn-like spike on the skin. You might also see calcification, though that's a rare find, mostly seen in scrotal cysts. And finally, while it is exceedingly rare, malignancy can actually happen, usually manifesting as a basal cell carcinoma. All right, final stretch. Section 5, Surgical Treatment Strategies. Let's scrub in and look at definitive management.
So, total excision is always our end goal. But hold your horses. If a patient walks into your clinic and that cyst is actively infected, you absolutely must follow this strict 3-step protocol. Step 1, start them on preliminary antibiotics. Step 2, wait. Seriously, you have to wait until the active infection and inflammation have entirely cooled off. Step 3, only then do you go in for the total excision. If you try to operate on an angry infected cyst, dissecting that delicate wall is basically impossible and your recurrence rate goes through the roof.
Now, once you're ready to remove a cyst under local anesthesia, you've got 2 main tricks up your sleeve. First is the dissection method. You make a nice elliptical incision that carefully takes the punctum with it, and then you meticulously dissect the intact cyst right out of the surrounding skin. This is actually perfect for cysts that were previously infected because the old inflammation scars the wall, making it thicker and way easier to dissect. Your other option is the incision avulsion technique. This is a bit quicker. You incise directly into the cyst, squeeze out some of the contents to deflate it, grab the cyst wall with forceps, and just carefully avulse or pull the whole sac right out. But no matter which technique you choose, there is one absolute, non-negotiable surgical golden rule here. The entire cyst wall must be completely removed. I mean, every last bit. If you leave even a tiny microscopic fragment of that squamous epithelial lining behind, recurrence isn't just possible, it is practically inevitable. It will come back. Finally, we need to talk about scrotal cysts, because these require a very specific, stepped approach. A solitary scrotal cyst? Easy, just a standard excision. If there are multiple cysts clustered on a specific part of the scrotum, you actually have to excise that entire affected patch of scrotal skin along with the cysts. But in severe cases where cysts are widely scattered over the entire scrotum, things get intense. You have to excise the whole scrotal skin. And to protect the testes, the surgeon literally creates subcutaneous pockets on the medial side of the patient's thighs and safely relocates the testes into them. It's a massive escalation from a simple blocked duct. We've covered some serious ground in this explainer today, starting from a microscopic blocked epithelial duct all the way up to complex scrotal reconstruction. Seeing how this pathology seamlessly progresses from a basic histological quirk to demanding such varied surgical strategies is exactly what's going to make you stand out on the wards. So, here's a thought to leave you with. The next time you see a seemingly simple skin-fixed swelling, how will you methodically prove its identity, anticipate its worst-case complications, and plan the flawless surgical strike to ensure it never comes back? Think on that. Thanks for hanging out with me on this explainer, and keep studying hard.